My name is Luke Maese. I'm a associate professor at the University of Utah in the Department of Pediatrics, Division of Hematology Oncology. Work at the Huntsman Cancer Institute and Primary Children's Hospital. Today we'll be discussing the key clinical considerations for asparaginase-based regimens in pediatric versus um, adolescent and young adult patients with acute lymphoblastic leukemia. So when I think about this question, I separate it into two categories really: the medical and then the psychosocial aspects of these two different populations. So when we think about the medical side, um, younger children, their body composition is typically made up a little bit differently. While younger children can be obese, older teenagers and young adults, obesity is more prevalent, and the degree of obesity can be more prevalent. And so when we think about giving chemotherapy to patients of different body habitus, this impacts the potential side effects that they may encounter throughout therapy. And when you think about asparaginase-based regimens for ALL or acute lymphoblastic leukemia versus non-asparaginase-based regimens, a lot of the consideration is the toxicity or side effects, adverse effects of the treatments that you're giving. And we know with asparaginase there is some increased side effects in those patients who are obese. And I would this is a consideration when we think about these choices that we make in children versus young adults. These sorts of side effects, which include liver toxicity, pancreatitis, thrombosis, and hypersensitivity. While some of these side effects aren't necessarily related to obesity, some are, and it's important to make that note. On the subject of hypersensitivity, we have seen that more younger patients actually are seem to exhibit more hypersensitivity or allergic reaction to asparaginase than older patients. So this is also something to consider. But again, not something that necessarily directs me one way or the other. I think outside of the toxicity that it could be impacting someone's choice, I also think about the efficacy and what's been demonstrated with asparaginase-based regimens versus not, and what the data shows you within the particular population that you're treating, whether it be a child or an adolescent or young adult. In pediatrics, we exclusively, for the most part, use asparaginase-based regimens. This is what's been demonstrated to be of the most success so far. And in the adolescent young adult, there is different approaches to using non-asparaginase-based regimens. But what I do is I consider the patient and what the data shows, and what it has shown to be the most effective in terms of treatment. And for the most part, asparaginase-based regimens have demonstrated superior efficacy. But again, this can be debated, and people can have different opinions on these things. Outside of efficacy and adverse events or toxicity, I also think about the psychosocial nature of the differences between these populations of patients. And again, when we're talking about asparaginase or other therapies, these are things that we need to take into account. So in the pediatric patient population, you have parents that are caring for their children. They're very typically, the parents are the ones who are responsible. They are very compliant. They drive the picture in terms of the treatment and the compliance with therapy. And so it's more controllable. And so when you think about asparaginase, you think about some side effects and things, and you think about when you need to get this drug, and you want to make sure people are going to be compliant with the therapy, asparaginase and other. And so for us in the pediatric world, we have a little bit more control. But when you start talking about a young adolescent, a young adult who may or may not be under the care of their parents, or guardians or loved ones, they're more responsible by themselves. I think these are things that we have to keep in mind in terms of their ability to comply with therapy. And whether using asparaginase-based regimen or not, this can impact compliance due to the complicated nature of some of the different protocols we use. And with our pediatric protocols, they are a little bit more complicated. There's a little bit more involved, and it does take, a greater degree of compliance. But again, something that most clinicians can get past when they have conversations with their individual patients. And then going along with this, not necessarily a patient situation or family situation, but the provider situation and the institution that they're at, the institution that's supporting them. Are they familiar with asparaginase-based regimens? In pediatrics, this is not something we really worry about, again, as we use this very often. But in other young adult hospitals, they may not be as familiar with asparaginase-based regimens and not have the expertise to understand these protocols, and particularly asparaginase and its toxicity profile, and how to abrogate some of those toxicities and how to respond to them. And so this sometimes impacts centers' ability to choose an asparaginase-based regimen. What I would recommend is if you're seeing a patient with ALL at a center where you don't see as many of these patients, consulting with a center that's a little bit larger, or consulting with your local pediatric center who sees more B-cell ALL or T-cell ALL, and can help guide you in some of these decision making in the decision making process, but also work together on taking care of these patients, which we often do here at our institution in Utah. So lots of considerations, but these are good discussions to have within your group and outside of your group, as we strive to provide our patients with ALL the best care possible.